Hello, everyone. I'm Rashmi Verma. I'm a neuro-ophthalmologist at the Northwell group of physicians, and I'm assistant professor at the Zucker School of Medicine as well. Today, I'm going to talk to you about the neuro-ophthalmic exam, or in short, about who's a neuro-ophthalmologist, why do you need to see a neuro-ophthalmologist, what to expect, when is a good time to wait, when is a good time to not wait, and some of the common diseases that a neuro-ophthalmologist deals with. So, a neuro-ophthalmologist is someone who deals with diseases of the brain and diseases of the eye as well. But who is a neuro-ophthalmologist? I hear this question so often, not only from my friends or acquaintances, but even the patients who walk in. Why do I need to see a neuro-ophthalmologist? And who is a neuro-ophthalmologist? What do you do? Do you treat neuro patients, patients who have problems with the nervous system, or do you treat ophtho patients, patients who have diseases of the eye? And the answer is I treat and manage both. So it's mostly patients who have diseases of the eye in relation to the brain, or something that happened in the brain to affect the eyes. So some common things would be like a stroke that's affecting your vision, or diseases of the optic nerve that are leading to loss of vision. So I'm going to talk over most of these in some detail, and some common reasons when you would need to see a neuro-ophthalmologist are, to begin with, visual loss. This is something that is very devastating when it happens to a patient. It can happen in one eye, which is called monocular. It can happen in both eyes, which is binocular. The causes of visual loss are many and varied, and it really depends on the patient profile, the underlying disease process. It could be as simple as just a perception of not being able to see, or something very complex as inflammation of the optic nerve leading to complete and irreversible visual loss. But we'll talk about these in more detail. Sometimes there could be photopsias, which are flashing lights or zigzag lines. In our language, we call them photification spectra. These are associated with migraine headaches, but sometimes you could have flashing lights or some other visual symptoms in association with diseases of the neurological system as well. To start with, you could have a visual field loss. So as you can see, the left side of the visual field is completely black, and the patient is unable to see on the left side of the eye. So sometimes patients are not able to tell if it is the left eye or is it the left half of the visual field. And how I tell the patients they can find out is cover one eye and then cover the other. So for example, if you have visual loss just from the left eye, if you cover your right eye, you cannot see anything, but if you cover your left eye, you can see everything. However, if you have a visual field loss on the left side of your visual fields, if you cover your right eye, you cannot see on the left half of your visual field, and if you cover your right eye, you still cannot see on the left half of your visual field. So one part of your field of vision is missing from either eye. And this visual field loss occurs most commonly as a result of a stroke, more specifically a stroke in the posterior most part of your brain. And this is sort of an emergency. Of course, a patient with a stroke needs to be rushed to the nearest emergency room, but also to deal with the consequences, which is this visual field loss, is very important. So this is where a neuro-ophthalmologist comes in. We would do testing to find out the exact extent of the visual field loss, and then counsel you about your life post-stroke, which is not only carrying on your daily activities, but in terms of driving, which is more important. And we'll talk about all of these. Another very common visual field is this. It is missing lower half of your visual field. So one eye is missing one half of the visual fields. Patients can wake up like this and they can complain that either the upper half or the lower half of their visual field is missing. This happens very commonly in diseases of the optic nerve, which is known as NAION, or non-arteritic anterior ischemic optic neuropathy, which is basically a mini stroke to the optic nerve or loss of blood supply to the optic nerve. And the way the blood is supplied leads to this pattern of the visual field, but is very classic for these patients. Again, these patients are usually patients who are also at risk of stroke in the brain. So they are usually more than 50 years of age. They have comorbidities like high blood pressure, diabetes, high cholesterol, but also it can happen in younger population who have obstructive sleep apnea, for instance, or who are using some medications that can cause the loss of blood supply to the optic nerve. So a visit to your primary care doctor, to your eye doctor, and to a neuro-ophthalmologist is warranted. Another type of visual field defect that I want to talk about is this. It is a bitemporal or loss of the outer half of your visual fields. And again, if you cover one eye, you can see the outer half of your visual field is missing. And if you cover the other eye has loss of the outer visual field. And this most commonly occurs in patients with pituitary tumors or other midline tumors. In younger population, it could be a craniopharyngioma. And patients may describe this as a tunnel vision. They could be bumping into things on the right or left side. Again, they need to go see their eye doctor, or if this is more severe, more acute, or happens suddenly, a visit to the nearest emergency room is warranted. Some other things that patients can experience is a scotoma. It is something that is either obstructing the visual field or the patient cannot see that part of the visual field. This is an example of a positive scotoma where the patient feels that something is blocking their field of vision. It can happen in patients with optic neuritis or inflammation of the optic nerve, or optic neuropathy, which is involvement of the optic nerve due to other causes. Most commonly, optic neuritis can happen in patients with a demyelinating disease called multiple sclerosis or some other demyelinating diseases as well. This is something that is frightening, but in most cases, less serious. This is a photofication spectra that patients with migraine headaches can experience from time to time. But again, in elderly patients who have vascular risk factors, we need to rule out other serious problems as well. This is a negative scotoma. So just going back briefly, this is a positive scotoma where the patient feels that something is obstructing their field of vision. This is a negative scotoma where they cannot see in that field of vision, either partly or fully. Another very acute and could be very serious symptom is double vision. And it can look like this. If you look at the slide for 30 seconds, you might be very uncomfortable, but patients who actually have double vision are experiencing this all the time. Sudden onset of double vision in an elderly patient over 50 years of age with vascular risk factors can signify a stroke. And again, this needs an emergent evaluation in the urgent care or the nearest ER. Double vision can also happen in young patients who have demyelinating diseases, multiple sclerosis, for instance. Myasthenia gravis and thyroid disease are some of the other conditions that can give you double vision. They can happen in patients of any age, but most commonly in middle-aged and elderly patients. The way that the double vision could be more serious is, again, if you cover one eye and the double goes away, that means that it is because of misalignment of the eyes. And the eyes can look like this, or they can look like this. So if you see one eye is up and down, and here one eye is turned in, and the other eye is normal. So causes of double vision need to be ruled out. We need to find out what's going on. Most commonly, if it is of sudden and acute nature, then it can signify diseases that can affect your nervous system or even one of the muscles of the eye. So a visit to your ophthalmologist if the double vision has been going on for some time, or a visit to the ER if the double vision is acute. Double vision can sometimes also be because of age-related muscular weakness, and it is common and less serious cause. But in those cases, the double vision usually happens over a period of weeks to months and not acutely over a period of days. This is again something that we frequently encounter. It's a ptosis or a lid droop. It can happen in a child. He can be born with it. It can be congenital. In those cases, it is more a patient of oculoplastics or the ophthalmic surgeon. But if it happens in a young or middle-aged patient, then it could signify something more serious, like a stroke of the third nerve or myasthenia gravis. Or in some instances, the lid can be retracted, in which case it can signify thyroid eye disease. Loss of color vision or changes in color vision and changes in brightness can happen in a lot of diseases of the optic nerve, sometimes also of the retina, but more commonly, diseases of the optic nerve lead to loss of color vision and contrast and changes in brightness. Colors can look washed out, especially when comparing one eye to the other. And the best way to do this again is cover one eye and look from the affected eye and then compare it with the normal eye. This is something that could be, again, very frightening if it happens suddenly. This is a difference in pupil size. It is more noticeable in patients who have lighter colored irises. In patients with darker color, it might be noticed accidentally while looking in the mirror, or someone else may point it out to them. In this case, if you look at it, it's actually the left eye, which is not only having a difference in the pupil size, in which the pupil is smaller, but also has drooping of the upper lid. This is most commonly encountered in a condition called Horner syndrome, which again can happen with a stroke, with a dissection of the blood vessel in your neck. And the more common causes can be trauma, or even chiropractic manipulation or stretching. Even something benign as yoga or Pilates can sometimes stretch the blood vessels in the neck and cause this kind of ophthalmic condition. It can sometimes even happen spontaneously in patients who are prone to having this or who have highly elastic joints and connective tissue. Again, once this happens, patients may have blurry vision in addition to the difference in pupil size. They may have neck pain or not, but going to a nearest eye doctor or even a neurologist or the ER is recommended. Here, if you see, the affected pupil is larger, and this can sometimes happen in an irreversible but benign condition, which is harmless. It's called Adie's tonic pupil. Patients can have glare and they can have difficulty focusing. They can notice the difference in the pupil size. It can happen in one eye, or it can also happen in both eyes. And it's a degenerative condition, but it's harmless, although patients may have subjective symptoms like glare and blurring of vision and may need time or some help with glasses to get used to. So what do you do if you encounter any of those above problems? Step 1, see your primary doctor or your regular ophthalmologist. If the problem is it's not acute or it's been going on for some time, you might have some time on hand. But if it is an abrupt change or an abrupt problem, then you may need to go to the nearest ER. Sometimes you can call your primary care doctor and they may direct you appropriately either to a neurologist or to an ophthalmologist, or go directly to the neuro-ophthalmologist if needed. So what to expect? I have patients in my office all the time and they are like, we didn't expect this. We didn't expect this test. It makes me very nervous. I didn't expect to be here for 3 hours. But the typical neuro-ophthalmic exam lasts 2 to 3 hours because depending on what condition you have, we may be needing to do a lot of tests. The first of which could be, the first is an extensive history. So we might be talking to you for 20 to 30 minutes and trying to tease out the exact chronology of events or the exact problem. And then this is the slit lamp exam. It's a bright light, but this is how it is designed. The bright light helps us to see and diagnose various problems in different parts of the eye. There's a yellow light, there's sometimes also a green or a blue light, and this is what we start off with. Sometimes we might start off with something else, which is a Prism test. This is especially useful in patients who have double vision And it could be cumbersome and annoying and sometimes very disturbing, because patients who have double vision also have nausea and dizziness. But this is the only way to tease out the problem and help you. There's very important part of the exam, which is automated perimetry. It's also the most popular form of testing a visual field for the patient. It has age standardized and normal population standardized data that helps us to determine the visual fields that I was showing you earlier, and it can give us a better idea of your problem. We do need to dilate. We use eye drops to dilate your pupils so that we're able to better look in the back and diagnose some common problems, which we'll talk about. This is something that is getting obsolete in COVID times, direct ophthalmoscopy or the fundus exam, in which we use the handheld direct ophthalmoscope to come really close to the patient, even closer than the picture depicts, and try to look in the back. But of course, we have more sophisticated instruments like the indirect ophthalmoscopy, where we can use something on our head, which is an indirect ophthalmoscope, and use a lens to better look in the eye, not only in the center, but also in the periphery. And of course, we can combine a lot of other lenses with the slit lamp to take a better look at the optic nerve and find out what's going on. And this is what we might find. This is the view from the other side. This is disc swelling or edema of the optic nerve, and it can happen in a variety of diseases. It is something somewhat similar to this, which is papilloedema. This is disc edema due to raised intracranial pressure. Now, disc edema can be because of optic neuritis in a younger patient, or optic neuropathy due to other causes, inflammatory, infiltrative, or cancer associated in an older patient. But presence of disc swelling needs other investigations to find out why the patient is having this. And in association with their other symptoms, we are able to reach a diagnosis with performing other tests, as I said, a visual field and a slit lamp exam and indirect ophthalmoscopy. Papilloedema or raised intracranial pressure causing disc edema is most commonly found in some diseases. In young patients, it can happen in patients with IIH or idiopathic intracranial hypertension. It's a mouthful, but what it signifies is there is raised pressure in the brain due to some causes, and that pressure is being reflected to the optic nerve in the form of swelling, and that swelling can sometimes be severe enough to cause the hemorrhages, as is shown here. So, for this, the patient may complain of headache, ringing in their ears, vision problems, may also have some double vision, and then we need further testing in order to find out if it is really due to just raised pressure or something else. A very common and life-threatening problem or disease that can be thrombosis in the superior veins in the head, and that needs to be excluded by imaging, or most commonly known as MRV, or magnetic resonance venography, which can show if there's a thrombus in the veins causing the raised pressure or not. This is something that we call most commonly as a cause of pseudopapilloedema, or not true or false papilloedema. And these are disc drusen. These are deposits that can actually calcify in the optic disc, and they can give the disc a lumpy, bumpy appearance. But sometimes if they're not this superficial, they can give the appearance of a swollen optic nerve, and it may be necessary to tease out whether this is an actual swelling or just a false swelling or a pseudopapilloedema, because the management of disc drusen is basically monitor and symptomatic, but the management of papilloedema is entirely different based on the reason for the raised pressure in the head. This is a very common condition that we encounter as neuro-ophthalmologists in patients who are 50 years of age with vascular risk factors like high blood pressure, diabetes, or high cholesterol. The blood pressure, in addition to being high or very low, can have fluctuations, and the blood pressure dropping low at night can be one of the causes of causing this. So there is inadequate blood supply to the optic nerve, and this leads to cutoff of the blood supply or infarction or a mini stroke, which we more commonly use the term to explain to patients, and it can lead to swelling or ischemia, and then it can lead to more infarction or cutoff of the blood supply. It is a mini stroke to the optic nerve, so we need to rule out other risk factors for stroke because it can herald a warning sign of a stroke happening in the brain as well. Patients need to be evaluated by not only by their primary care doctor, but also by their neurologist in conjunction with the neuro-ophthalmologist to elaborate their vascular risk factors for a stroke and to address those risk factors. If the patient is already not on a baby aspirin, we'll typically put them on a baby aspirin, which helps in secondary prophylaxis to reduce the risk of a stroke in the future, not only in the other eye, but also in the brain. And this is the visual field that I'd shown you earlier, but this is the visual field that can be associated with NAION or non-arteritic optic neuropathy. There is something that is much more serious and is called arteritic ischemic optic neuropathy. And this causes sudden and severe vision loss as a result of inflammation in the arteries of the head, more specifically the temporal arteries that run along your temples. But the inflammation can happen in any of the arteries of your body and can affect systemic organs as well. This is an ophthalmic emergency, and patients need to be rushed to the nearest ER, and the pallid disc edema signifies that there is complete loss of blood supply to the optic nerve. They usually need IV steroids for 3 to 5 days, depending on the severity, and we do need to protect the other eye. This is something that requires multidisciplinary approach with a neurologist, neuro-ophthalmologist, rheumatologist. We may need a vascular surgeon to perform a biopsy of the temporal artery and send it for pathology to find out if we are actually dealing with the disease process or if there is something else that's masquerading as this. But more importantly, to confirm the diagnosis, because these patients may need steroids for many, many years. They need to be maintained on a low-dose steroid to prevent a risk of having the same problem in the other eye or even in the body. So this is something that needs to be really kept in the back of your mind in cases of sudden vision loss, especially in patients over 50, again, with a lot of vascular risk factors. What to expect after you have undergone the 3 hours of neuro-ophthalmic exam, after we have grilled you and we have tortured you with the bright lights. Your neuro-ophthalmologist will talk to you about neuroimaging as appropriate when needed, especially in patients who are suspected of having a stroke either in the brain or in the optic nerve, or if we are suspecting high pressure in the brain, in which case we not only need MRI, we would need an MRV, as I had mentioned, which is looking at the blood vessels, specifically the veins in the back of your head. And in some cases, we need a lumbar puncture. And again, patients don't know what to expect. The lumbar puncture is something that you need to find out if the pressure in the head is high or if there is an infection in the brain. It's not done in the office. It's typically done either in the hospital as an inpatient, or it can be done in the ER. It can sometimes be done with the radiology department in conjunction with fluoroscopic guidance, which gives them a better view and gives us a better result as well. So this is how we do it. The patient can be lying on their side or they can be sitting upright. There is a small, tiny needle that goes in the back through which we extract the fluid that coats your spinal cord. We measure the opening pressure, which is a direct reflection of the pressure in your brain. And we take out some of the fluid, a few milliliters, to send it for CSF analysis, which gives us a wealth of information. And then based on what we find, the treatment. So some of the neuro-ophthalmic conditions are treatable, like IIH or idiopathic intracranial hypertension. It is a disease that affects adolescent and young girls. The girls could be in their teens or 20s. It can also affect boys, especially very young boys who are like in their teens or not even like 8 or 9 years of age. I have a lot of male population that I'm treating as well. But like I said, their symptoms could be headache, dizziness, ringing in their ears, double vision sometimes. We get the neuroimaging and the lumbar puncture, we have our diagnosis, and the treatment is something that is very simple and very safe. It's a medication called acetazolamide. It's been around for many, many years, and it's proven to be very safe even in children or even in pregnant patients after the first trimester, breastfeeding patients, or even elderly patients. And we typically have to follow these patients over months to years before we can finally achieve remission and describe them to be treatment-free or treated, or the condition is resolved. These conditions can always recur, and so long-term follow-up with your neuro-ophthalmologist is very essential. There's other diseases like optic neuritis, which can happen in conjunction with other demyelinating disease like multiple sclerosis. And the optic neuritis is just a manifestation of the inflammation that's going on in the brain. So the optic neuritis is treated with IV steroids, and then later maybe a course of oral steroids for 11 days or sometimes longer. And the inflammation typically settles down. But the underlying disease process is to be treated by a neurologist or an MS specialist or a neuroimmunologist. And the optic neuritis can recur based on how well the underlying disease process or the multiple sclerosis is controlled and what the disease behaves like in a particular individual, which can be different for every patient. So in cases where we have a relapse of optic neuritis, again, we can treat them with steroids. But if we suspect that it could be some other demyelinating disease, which can be more serious, like neuromyelitis optica or MOG-associated antibodies, the treatment can actually be more protracted. We might have to try other agents like rituximab or azathioprine. In some cases, we need to filter out the plasma, do a plasma exchange or a plex that is more invasive and needs to be done in the hospital with extended stay. If it is something that we talked about, like an ischemic optic neuropathy, which happens in elderly patients, those diseases can sometimes not be amenable to treatment in the sense that they cannot get the vision back because a mini stroke damages some of the optic nerve fibers. Whatever damage has been done cannot be retrieved back, but what we can do is prevent further damage. We can do a secondary prophylaxis to retrieve the vision or preserve the vision that is left in that eye, and to preserve the vision in the other eye, also to prevent a stroke and manage the vascular risk factors. So the patients are typically counseled about diet and lifestyle modification, exercise, eating a healthier diet, giving up smoking, or managing their other vascular risk factors. There is other conditions like the visual field defect because of stroke. Again, the visual field defect cannot be treated because it's happened as the part of the brain that is responsible for that visual field has been damaged. But what we can prevent is further damage, further strokes. We can help with the patient getting used to the visual field defect. And in some cases, they do improve over a period of few months to years, up to 1 year. And we can work on that with the patient as well. Counseling is very important, and we typically try to have the patients bring in their family so we can talk to them and discuss the other options, whether there is treatment available or not, whether we need to send the patient to the ER or if we need to have them adopt other lifestyle changes. So this is what I have for you today, and I thank you for your attention. I hope I was able to explain some of the more common conditions that can be associated with a neuro-ophthalmic disease process and the need to see a neuro-ophthalmologist, or what to expect when you go in for a neuro-ophthalmic exam. Feel free to reach out to us if you have any more questions. There's a lot of resources online. More specifically, if you go online, there is something called NANOS, or the North American Neuro-Ophthalmic Society website, and that has a lot of educational brochures for patients with the more common neuro-ophthalmic conditions that can be encountered in common practice. So good luck.